Hi, my name is Dr. Christy Dunst, and I'm an esophageal specialist with the Center for Advanced Surgery at the Oregon Clinic in Portland. My partners and I have dedicated our entire careers and practice to taking care of patients with esophageal disorders. And today, we'd like to talk to you about gastroesophageal reflux.
Heartburn is a classic symptom of gastroesophageal reflux disease. In most patients, heartburn is well controlled with acid suppression medications, particularly the proton pump inhibitors. But over time, heartburn symptoms can progress.
For those patients, surgical management becomes very important.
Let's start with the anatomy. The esophagus connects your mouth to the stomach, and the diaphragm is a muscular shelf that separates your chest from your abdomen. Normally, your entire stomach is below the diaphragm. When you swallow, food travels through the esophagus to the stomach, which holds the food and delivers it slowly to the intestine. Normally, this occurs without much backflow from the stomach into the esophagus because of the reflux barrier that exists between the two organs. The normal junction between the esophagus and stomach is a one-way valve mechanism that opens to allow food and liquid to enter the stomach but closes to prevent backflow. The components of the gastroesophageal junction valve mechanism work together to prevent reflux. But in gastroesophageal reflux disease, this valve mechanism is broken. This situation can not only lead to symptoms, but physical complications. Inflammation or esophagitis is where the acid physically burns the esophagus and causes localized inflammation, often felt as heartburn, but sometimes silent and can lead to strictures. In some patients, uncontrolled reflux will lead to a condition known as Barrett's esophagus, which is the leading risk factor or precursor for esophageal cancer. Gastroesophageal reflux disease can also be associated with a condition known as a hiatal hernia. Although not all hiatal hernias pose a problem, they may represent a significant increase in symptoms when they develop. Other, more rare types of hernias exist that may mimic the signs and symptoms of gastroesophageal reflux disease. Although not all hernias require special treatment, refractory symptoms due to hernias typically require surgical correction. Whether the hernia is big or small, a hiatal hernia repair is a standard part of gastroesophageal reflux surgery.
The next segment shows a real surgery video, so if you're sensitive, maybe skip forward.
After the hernia is reduced and the normal anatomy of the esophagus and stomach is restored, the hole in the diaphragm must be repaired with sutures. Sometimes an absorbable mesh is used to strengthen the repair. This mesh goes away in a year or less, but serves to support the tissues as they heal.
Currently, there are 3 surgical methods to correct the gastroesophageal reflux mechanism. We'll discuss each of those next.
The 3 options that we will discuss next is the gold standard fundoplication, often called a Nissen or a partial, depending on how it's done, the combined laparoscopic endoscopic fundoplication, also known as CTIF, and the magnetic sphincter augmentation, also known as LINX. The standard fundoplication has been performed for decades with stable and reliable results. After the hiatal hernia is repaired, the technique uses the top of the stomach or fundus wrapped around the bottom of the esophagus to recreate the reflux mechanism that has been destroyed. This procedure is accomplished with standard sutures and can be adjusted from a complete 360-degree wrap to a partial fundoplication as needed. The reflux valve can also be created using a device that is placed through the mouth. Here, the fundoplication is created by placing sutures called H-fasteners through the mouth. Once the device is positioned across the gastroesophageal junction with the aid of the camera on the flexible endoscope, the tissue is positioned appropriately and secured by placing the permanent sutures using the device trigger handle to recreate the reflux barrier valve. The device is then repositioned until a partial fundoplication has been created and secure. Usually about 20 fasteners are placed during the procedure. With the combined endoscopic laparoscopic approach, the hiatal hernia is repaired using the typical techniques, which also then allows for additional sutures to be placed as needed. Lastly, the magnetic lower esophageal sphincter augmentation device, or LINX, is the simplest surgical anti-reflux option. After the hiatal hernia repair, the esophagus is measured, an appropriately sized device is placed around the bottom of the esophagus to reinforce the reflux mechanism. The foregut surgeons at the Oregon Clinic Center for Advanced Surgery has extensive experience performing all three options discussed here and have been leading investigators on many of the original published research trials. We have found that each option has excellent outcomes in carefully selected patients. However, gastroesophageal reflux disease is a complex disorder with a wide range of coexisting conditions that impact the decision as to which option is best for an individual patient. Disease severity and other patient factors weigh in to each surgical decision by our group.
Thank you for joining us. We hope that this was helpful for you to understand the different treatment options that may be available to you as you are seeking surgical alternatives to the medical management of your gastroesophageal reflux disease.